And again, I thought that I was going to be giving this yesterday. Say, and so so a lot of what's in here is redundant, but this is a talk that hopefully people won't throw tomatoes at me for. It's a little bit more provocative. I think the question, the other elephant in the room is, are these therapies going to change, everything that we do? And I think, say we're going to learn a lot from these, but I think, I think that a lot of what we've learned, we're going to still be applying. And so what I hope to do in the next 10 minutes is to very quickly go through what our initial therapies are, which we've talked about, and then what are our treatment goals? Because this is going to really get to that question: Are the TKIs going to change completely what we do? What data do we have with TKIs as initial therapy? And then what are the limitations of integrating these treatments with our current therapies? And other better things. Maybe we should throw away what we're doing and go to new things. And then what things are going to be applied? So we've heard a whole lot about this, and I would say, some people may debate, but this is what we're doing currently for younger fit patients. I think most people would agree that we would do FCR. Our treatment goal, particularly for the favorable risk group, is to treat them to MRD negative status, where they have an extended remission, and there's relatively minimal long-term side effects with this. For the older patients, we've heard that obinutuzumab plus chlorambucil is a good option. As ofatumumab plus chlorambucil is also a good option. And again, our goal here is disease control, reduction of therapy, and the potential to keep patients going and maybe attain MRD negative status, but probably in a smaller subset. In a deletion 17p, everybody knows how to treat these patients. Not. So we give high-dose methylprednisolone plus rituximab. Probably if we polled people in the room, there would be 8 to 10 other things that are done for these patients for initial therapy. So what are the problems and the advantages of our current therapy? Well, particularly with cytotoxic therapy with FCR, we see prolonged suppression of normal hematopoiesis and very profound suppression of this, the cellular immune system. And there are some patients that get FCR that never recover their B cells and have a chronic variable immune deficiency phenotype for the rest of their life. Say chemotherapy with FCR has been associated with MDS and AML in 3 to 10% of patients. And if you're in that group of patients, you're very likely going to die unless you die of something else. Chemotherapy can certainly, there's the potential. I don't think it's been unequivocally proven that it can drive clonal evolution, but I think a lot of people believe that this is a possibility. So, and then some patients are not going to tolerate chemoimmunotherapy. We really don't have anything for those patients then. But I would say at the same time, while these are sort of the problems with our current approaches, in both the young patients and in the elderly patients, we have a therapy that prolongs survival. And that's pretty darn good. That's much better than things were 2.5 decades ago. And in a subset of younger patients, you can attain a very, very prolonged remission, that with plateaus. And we saw these, and these are data from Bill Werda and Michael Keating and MD Anderson looking at their FCR experience. And again, there aren't very many studies that have been published in CLL where you have the appearance of a plateau, and this is at 10 years follow-up, and when you look at who's doing well, and we've talked about this, again, if you have IGVH mutated disease and favorable fish favorable fish markers, and you fall into this red group up here, I have a hard time. I'm probably the biggest believer in kinase inhibitors and these newer therapies, and you have to talk a long time with the patient, and really go through this. If you have a chance of the patient being disease-free at 10 years, with the 6 months of therapy. So the data with kinase inhibitors, say we really have limited data in the upfront setting. We've talked about the monotherapy study. 31 patients, somewhat under high risk. We have phase 3 studies that are ongoing, the RESONATE-2, which is closed, the cooperative group studies, and the European studies that are, that are just starting. And then we have one combination study with itolizumab and rituximab, 61 patients. So, really less than 100 patients total that we have data. These curves, are provocative. But we know, that everything always looks good, and it gets worse with time. And these curves, you can't get better than this. So we have to assume that, that as this is applied, we're going to see things fall a little bit. But the results are very provocative. And similarly, the study, and Rich talked about it, the itolizumab plus rituximab study in untreated patients, and we again look. And these patients are doing phenomenally well. And what's interesting is, despite a good number of patients going off therapy, at 12 months, a lot of them are still in remission. And as I said, the same thing with the ibrutinib study. There's a small subset of patients that went off, some as early as 6 months, and they still have not progressed. So there's something to learn here. So what are the advantages and limitations of replacing or integrating the kinase inhibitors with our current therapies? I think with each of these, there are different, there are different things that we have to consider. The first, itolizumab, Dr. Johnson and Sarah Herman published that there's very, very minimal interference with monoclonal antibody ADCC. So if you believe ADCC is important, then say this is not going to interfere with it. The adverse event profile in untreated patients, to me, is a little bit more problematic. Say the colitis and diarrhea, particularly if you're going to have to treat for a long time, the colitis and diarrhea, although manageable, it's something that patients don't like. And the LFT elevation was more frequent in this patient population. But then again, in most patients, you can stop the drug, it goes away, and then you can start at a lower dose. So it's manageable, but it's worrisome. With ibrutinib, it's well tolerated in a small population of untreated patients, but not everybody. I had somebody that went off of ibrutinib after 18 months with a rash that ultimately we attributed to ibrutinib. The cost, again, it's not a small token. That's not $94 a pill. And we could bring this down to 100,000 by assuming a little bit of non-compliance. But this is going to be challenging long term. And we don't know what itolizumab is going to cost, but it probably will not be half of ibrutinib's costs. So we just don't know that. And then finally, the off-target effects of these drugs. And as far as we know, that itolizumab, it just targets P110 delta and gamma, perhaps at higher dose. There are off targets of ibrutinib, including ITK, and this can be good or bad. So I'm going to talk just a little bit about this, and I don't want to take credit for this. So we have a brilliant postdoc who's hopefully going to be moving on to a faculty position soon, Jason Dubowski, who, working with other members in our lab, identified that that ibrutinib is a very potent inhibitor of ITK, and ITK is a kinase that's expressed in T cells and NK cells, and it has a redundant kinase called RLK. And so in most effector cells, the redundant RLK, can stand in place, and ibrutinib does not inhibit RLK. But Th2 cells only have ITK, and Th2 cells are the T cell subset that are more suppressive. They make IL-4, IL-10, and contribute to the immune suppression that's seen in CLL. And Jason showed very nicely, and this work was just recently published in Blood, that that in both in vitro systems as well as in vivo systems, that you could see inhibition of ITK biochemically. And in patients receiving ibrutinib, you saw a Th2 to Th1 cytokine change. Jennifer Wack showed the same thing with working with Jason in the TCL1 mouse. And looking at the ITK binding assay, we could show probe occupancy in vitro and in vivo. So this was shown nicely. And then in 2 mouse models of Th2 immunity, and one that was dealing with leishmania major, which is not a disease we deal with in North America, but it's a very significant disease in third world countries. You could give ibrutinib and actually treat leishmania, this by reverting the Th2 to Th1 immunity. And similar, using a Listeria monocytogenes model and giving Carlos TCL1 mouse Listeria monocytogenes with or without ibrutinib, the ibrutinib would rescue the mice from Listeria infection by promoting a Th1 T cell response. So that's good. What's the bad about inhibiting ITK? ITK is essential for NK cell dependent ADCC. It has nothing to do with direct killing, which is so there's not a viral deficit, but for antibody directed killing, it completely abrogates it. And this shows with alemtuzumab, which is probably the best antibody for mediating ADCC, and you see here we're looking at interferon gamma release, and you see with a very low dose of ibrutinib, you completely annihilate it. And the same thing with ADCC, and this is against autologous CLL cells. And say the group from Stanford collaborating with us showed this, showed the same thing in lymphoma cell lines, looking at ADCC in vitro, and then also in vivo models, and again looking at the DHL4 lymphoma model where ibrutinib has a little bit of activity. And rituximab has significant activity. When you give the two together, you revert back to the ibrutinib. You revert back to the ibrutinib line. And looking at a HER18 breast cancer cell model where Herceptin has activity, ibrutinib has no activity. When you give ibrutinib with Herceptin, you see complete abrogation of activity. So, suggesting that this. If you believe NK cell ADCC is important, this could present a problem. Well, does the biology suggest our best therapies, what are our best therapies to integrate with these kinase inhibitors? And, Nina sort of alluded to this, but I would offer some other possibilities. And as I said, ibrutinib, by virtue of inhibiting ITK and promoting a Th1 T cell response, and polarization could suggest the possibility of combination with T cell directed vaccines or the T cell checkpoint inhibitors such as the PD-1 antibody, the CTLA-4 antibody, lenalidomide, or the CC122 molecule that Celgene is developing. And similar thing could be said with adalimumab, because as I said earlier in my earlier talk, the P110 delta is necessary for T regulatory activity, and actually that's one of the PD markers that's used to follow for P110 delta inhibition is T regulatory activity in vivo or numbers. Let's say the BCL2 antagonists are obvious because they're active, but again, looking back at the old genetic studies, there's a paper describing BCL2 overexpressing. BCL2 overexpression rescuing XID B cells from apoptosis, and again we've heard that ABT199 is effective against ibrutinib-treated cells. CD37 is something that will be talked about a little bit tomorrow. Rosa Lampabella at OSU published a paper in Cancer Cells showing that there's a molecular mechanism for CD37 and adalimumab synergy, and then finally we've heard that what we really would like is, if we think this pathway is really, really, really important, then if we could target it with two BTK inhibitors, then it would be much more difficult, to acquire two mutations, to promote resistance. And so, if we had another BTK inhibitor that we could give with ibrutinib, and again, that's heretical, that might be a path to avoiding resistance. So moving forward, what strategies will be applied or may be applied? I think for young patients, where our goal is long-term remission and cure, and maybe we don't want to have them on continuous therapy, particularly if it's $100,000 a year. The FCR plus or minus a kinase inhibitor or novel therapy combinations, for a limited time period for the favorable risk group. I think some patients. If you talk young patients, you talk to them about FCR, you can talk to your blue in the face, and they're going to say, forget it, I don't want it. and so those patients, that maybe they'll go on a novel therapy combination. For the higher risk group, the 17P patients, maybe we're going to do novel therapy combinations, or an idea that we're very interested in is starting with ibrutinib and in taking them on to CAR T as consolidation, particularly for the 17P patients. For elderly patients where disease control is our goal, maintaining quality of life and less toxicity, a kinase inhibitor plus or minus a CD20 antibody, with the attempt to discontinue therapy. And I would probably say with ibrutinib or with other BTK inhibitors, the CD20 antibodies would be what I would choose. With a P110 delta inhibitor, I think CD37 molecularly makes a better choice for the antibody. Novel therapy combinations with the attempt to discontinue therapy. And then for some patients, continuous therapy may be what we choose or what they choose because they get on these medicines and they don't want to go off. And we've seen this with CML. So in conclusions, I'd say kinase inhibitors do change almost everything in CLL. The benefit of chemoimmunotherapy can be questioned, but it should not be discarded, particularly in younger patients who have low-risk disease. You can similarly question the benefit of antibodies, but again, we can't dismiss their importance because they have a survival advantage, and you don't walk away from something that has a survival advantage. I would say that we're blessed with the change that we have in front of us because our patients can hope for therapies in the future that will provide reduced side effects, and that rationally designed clinical trials with consideration of both on and off target effects of our different drugs will be important. And I think these medicines leave the future very bright for our patients. Thank you.